What we wanted to do was to give you an opportunity to ask questions, but before we do that, I mean, obviously, as you can hear from today, there's a whole pile of opportunities there for us, but challenges as well, because it is about us trying to find smarter and better ways of doing our work and developing this model of care. And even those last two research results and programs that were provided, they give us two opportunities we can look at and say, now, are we going to do that in our clinical environments? Are we going to look at the workforce models? What are the high-value services we're going to do? But before we do that, I might, because I've got three people that actually know what they're talking about rather than me, I'm going to firstly ask Paula to talk a little bit about what we're looking at from a clinical governance perspective in DHSV, but we're hoping to involve quite a lot of you at the same time. So Paula, it's yours.
Thanks, Deb. This morning you heard Dr. Brendan Murphy. He stated that clinical leaders are essentially the change agents. They're the ones who are armed with the data and they can shape the local agenda. He also said that innovation that's led by clinicians locally has got the best chance of success. So with that in mind, it's important that you, the clinicians, are involved. We at DHSV have just developed a framework for clinical leadership. Now, that framework presents various avenues where clinicians can be involved. The main thrust of that is the Public Oral Health Leadership Council, which will be a new think tank that will be quite strategic in its view. It will look at model of care, clinical leadership, to ensure that that clinicians have a say in the way things are progressing. There will be some other groups, such as the Clinical Leadership in Practice group, which Hanny will be involved in, which will be looked at continuing to work on clinical guidelines, looking at clinical pathways, making sure that there are clinical audits developed that we can then put into our practice. Within that framework, there will also be avenues for peer review, and we're starting some great work at the moment at the Royal Dental Hospital of Melbourne with peer review in the different departments. So that's what we're doing in the clinical leadership space, and it fits in really nicely with the model of care because they're both interconnected. You can't really have models of care without ensuring that our clinical leaders and clinicians are talking to each other about clinical matters and helping develop the way forwards.
Thank you. And I think the other part of it too is we're actually having subgroups in relation to model of care that look at specific groups, of which Hanny and Paula will be very heavily involved with. But I'll ask Hanny to just have a bit of a discussion about where he sees the future too, because obviously for most of you, you'll know Hanny's been on this journey for a long time and has been one of the major contributors to some of the research. And, you know, we stand on his shoulders quite a lot. That's why he's looking a bit squished.
Thank you.
But Hanny, you know, we really want Hanny to keep taking us on that journey. So I'll just pass to Hanny and ask him to make his statements as well.
Okay, well, I think this is really a partnership. It has to be a partnership across health promotion, across the research area, across the clinical area. And in terms of models of care and the direction for models of care, we have to look at it from the perspective of primary prevention, secondary prevention, tertiary prevention, and involving within primary prevention the health promotion activities, the health professionals outside of dentistry that can actually support oral health, the ones that see the children before we even get to them, and how we can actually involve or extend the scope for them to be looking at oral health, similar to the midwife project that was just presented. From a secondary prevention perspective is for the groups that have actually started to demonstrate signs of disease. What are we going to do for them, and what are the services that we're going to provide? Is it going to be around reversing of the processes? We need to be looking at dental caries. We also need to be looking at periodontal disease. We can't just be looking at the hard tissues without dealing with the supporting structures. So the clinicians will have a big role in that. The clinical guidelines that we're developing will have a big role in the quality of the services that are being provided, because the model of care has to be linked to quality. Otherwise, we're going to be repeating restorations, doing treatments again, having repeat GAs, and so on and so forth. And then we've got tertiary prevention, where now we've lost some teeth or we've had some really advanced treatment done. We need to be thinking about what treatment we should be doing, and should we be doing a lot of the things that we are currently doing? Should we be thinking about the overall masticatory efficiency of the patient, rather than this is really nice to save that tooth and keep it? So that's sort of a perspective of what I think the model of care should be looking like. But it's a partnership. It's around policy, it's around clinical guidelines, it's around health promotion and population health, and also around quality of clinical services, I think.
Thanks, Hanny. And now I'll pass back to Martin. I mean, one of the good things that I think Martin has done is he's been on that journey and actually done it now, and been doing it for a few years. And I spent a lot of time talking to Martin, and I've heard the journey along the way, and you hear the trials and tribulations. It's not easy. It has been, you have to constantly review your practices and challenge it. And one of the things that I've been really impressed is the whole team. They do that. They really review what worked, what didn't work, and it isn't always easy. But I'll just pass to Martin, and maybe he can give us some other words of wisdom too.
Am I on? Yeah. Well, yeah, it's true. We had a meeting 3 weeks ago, and we just sort of threw everything out on the table again. We went through our model of care, and everybody sort of contributed. We went through the different parts of it, and the whole staff sort of contributed to that, and we came up with some changes. So if you're not constantly reviewing and improving, I don't think the model of care is a stagnant thing. It's a living, developing thing, especially when there's nothing to refer to, really. It seems like we're ahead of a lot of things, and it's quite exciting, but it's also quite challenging as well. And we're hoping that we will actually get some evidence soon. There's a guy who wanted to do some research into what we're doing, and I really look forward to that, because you need to have that confidence that you are doing the right thing. We've got anecdotal evidence, and we've got our clients sort of approving and giving us good feedback, and the staff are also giving us good feedback about what it's like to work within a model of care. But it would be really good to have some hard evidence and say, look, okay, this actually does work. And we don't have that yet, so I'm not sure what else you want me to say.
No,
but
that's fine.
it's trial and error, I suppose. And if you're willing to take risks, and you're willing to challenge sort of, I have to challenge some of DHSV's policies because it doesn't fit our model of care. And if enough people challenge them, then they'll have to change them. So,
Well done.
And that's actually a really good comment, because we actually all have to be part of the policy development. We all have to be the ones that make the decision about what we should be doing in this model of care. And this is where we do need clinical leadership. Leaving it to administrators to make the call on this is silly. And what we're asking is for you to be all part of this journey, so that you actually contribute to improving the oral health of all the people that we treat. And it's going to be a long journey. It's not going to happen overnight, and it's not going to be perfect, and we're going to make mistakes. But we're actually going to make a difference in the long run, and that's what's really exciting about it. And I just love the intellectual challenge of it all, because we've all been taught all this theory, and now we've got this fantastic opportunity to apply it. And you can see the successes in Martin's area. You see some of the work that Hanny's been doing and Paula's doing. It's just amazing watching these really, really great successes. And I see, all these new, oral health therapists with their working on adults now, Cert 4 people. it's a really exciting place to be, and there's some real opportunities. So I'll stop going on because I carry on a bit much. So what I'd like to do is open the floor for questions. We do have some roving microphones, so we'll ask people to wait for the microphone to get to them. And
There's one person over there you don't want to ask. Too late.
Hello, thanks everyone for a fantastic day, great concepts, great work being done. I'm picking up on the last point with Martin and Deb, and that's there's still a couple of dilemmas for me. One is what they do at North Richmond is, without data, clearly a good thing to do. It's in contravention of state government access policies, and I think they do it for the right reason. My second, and so there's a raft of issues there around, we can do adult recall, but essentially that's expected not to happen at a high level. If we're going to manage periodontal disease appropriately, then you have to have regular recall or the whole work is a waste of time. My second dilemma is the rigid funding formula, which still doesn't support a lot of the really good things that are talked about today, as in a lot of prevention and a lot of primary care approaches to patients and their families and their needs and so forth. It still largely looks good if you take a lot of teeth out and then replace them with dentures, and I'm exaggerating, but you know what I mean. So my question is, what's the HSV's position in terms of advocacy with government around access principles that ought to change to allow the sort of things we've talked about today, and a review of the rigid funding formula to also allow outcomes that we'd all like to see?
oh, you're right, Martin. Don't let him have the microphone again.
Listen to me.
Look, there's a couple of things. Firstly, with respect to access, my view is that there is no rule to say no recall, but what we have got a situation is each agency is funded via a funding model, which is basically a service item number based funding model. And my view is if you can do whatever you think is the right model within the funding you've got, do it. And I don't think there is actually a rule anymore from the department that says you can't recall or you can't do this. So, and I think that there is quite a lot of support from the department at the moment for models of care and for us to be innovative about the way that we're doing things. So I don't find anything other than utter support for it. And they recognise that we're on a journey. They recognise we haven't quite worked out what the right answer is. With respect to the model of care, the funding model, look, I've been on record many times about the fact I don't support a fee-for-service funding model. I don't think in a public health environment it drives the right behaviour. But I'm also a pragmatist, and I think it is the model that dentistry knows and understands and sort of loves. We just have to deal with it and work with it. I love it to be different, but it's the one we've got, and we just have to use that. That's one of the constraints of the model of care we have. Any other questions that people have?
I don't really have a question, but I just wanted to agree with my colleague over here that I don't feel supported in the, I personally put a lot of value into consulting with patients, educating patients, really strong emphasis on prevention and regular recalls, and I feel like due to the funding models that we have, as far as I understand, and the whip being cracked in terms of DWAs and funding and things like that, I can't practice in the way that I'd really like to practice in the public sphere, and I hope that changes because I'm really passionate about prevention and public service. Yeah.
Can I make a comment there? We don't individualise it as you are. We're looking at it as a team. So if the team has successes, then that's how we gauge our success. So if you have say you have a dental assistant doing all the oral health education, the patient still benefits from that, and it's a cheaper way of delivering that care. And no offence, but it's probably better Are you a dentist? Sorry. Yeah. Okay. But yeah, so that's the way we look at it. Anyway, we look at it as a team event. And again, the same with collecting DWAs, as I mentioned before. If you collect your DWAs as a team, well, it really doesn't matter, whether you did it or the DA got it or oral health therapist did it.
And certainly the workforce model that you use is going to have to be very relevant to the model of care with a focus on the patient. So if at the end of the day, the patient change in behavior is what we want, and their improvement in their oral health, then we have to work through a workforce model that actually will provide that. We were told today that we see 20% of the 30% that are eligible. Is that correct? And so if the dentists are involved in doing all the complex work, as well as the education, as well as the fluoride application, as well as the Fisher sealants, we're not going to be able to ever get to that 30% that we want to achieve. So it's around using our workforce in a really smart way and getting the outcome that we want for our patient.
I hate DWAs.
Have we got any other questions that people would like to ask? Yes, in the middle.
I'm not sure if mine is a question or a comment. I wanted to go back to perhaps Dr. Murphy's comments, which seem to be prefaced by the fact that there are increasing wages and what he said was a less productive workforce. But also mentioned that the workforce is working with perhaps outmoded systems and things like that. So, and some of prefacing, I guess, with a workforce working less efficiently. Takes an economic rationalist view of I guess, workforce and how to make it work. And when I'm saying less efficient, that's in inverted commas. And sometimes I worry that working smarter, that's inverted commas too, is actually working cheaper. So that's just my comment.
I'll just make a comment to that. There's quite a lot of research around, and in fact just in general health, the amount of money that's coming into the health system at the rate it's coming in is not anywhere near the rate that people's salaries, or the salary cost has gone up. So that's a fact. The other thing too is there's quite a lot of productivity studies done across the health sector which show there hasn't been over quite a long period of time any productivity improvements, even with all the new technology and new ideas and techniques around. So he's using that sort of information, and that article that I was referring to also states the same thing, is that we don't seem to have actually got anywhere, and health is, people are really worried. I mean, I worked in Canberra for about 4 years, and they were really worried in the ACT because they could see in a very short period of time, I think it was about within 20 years, they saw that 50% of all of their funds were going to go into just funding the health system. And they knew they had to change it. If they don't change their model, their workforce model, we as a community can't afford it. And in fact, everybody in this room, we need to change it because we're going to be the recipients of it in 20 years' time, and we will not be able to afford the care. And that's one of the things I think that Brendan's so passionate about it, because he's saying if we don't get a lot smarter about it, and yes, it is cheaper, but he is not denying that we have to maintain quality. In fact, he's really strong on that, because there's a lot of evidence. There's no reduction in quality by having different people doing it at all. There's well-trained people that can do those services. And some experience that I've had in in acute health, particularly bring in patient services assistants into nursing or into wards, medical wards, we actually did a full survey of what our registered nurses were doing, and it was really quite incredible. They were doing about 40 to 50% of their day was spent on doing things that did not really relate to their nursing qualifications. And so what we did was we used these patient services assistants to in fact take on those roles and free them up to actually care for their patients. It made a huge difference. And the patients were really happy. That the nursing staff said, "You ever get rid of those people, we'll go on strike." And yet it was quite a heavily unionised issue, but it was a really successful issue. And that's the sort of model that we need to be looking at in dentistry. Well, we've already got the right people, we've got the right workforce, but we just don't use them well, and that's one of the things that I find overwhelming, particularly in Victoria. I think we don't do it as well as other states do even, and there's lots of places where we can use other people within our workforce really, really well, and we've just got to challenge ourselves. Can I do oral health instruction as a dentist as well as this well-trained dental assistant with a Cert 4 who's passionate about it? Well, probably not. And we need to be realistic about it. So I think that Brendan is not saying he wants to diminish quality. He's saying he wants to maintain quality, in fact even improve it, because he thinks he's going to have the right people doing the right jobs on the right people.
Great. We have time for one last question.
Can I answer? I mean, I'm not sure if this is an answer or a comment, because it ties together with what Shane was saying about funding, and it's a bigger issue about the price and cost of things versus the value. And if you go to the community and the clients, they say we value health education. We value someone taking care of our overall health. We value people spending time with us just talking. And there's no price or cost on, well, there's a cost, but you've got to separate what the value to the community is in this argument. And I don't think DWAs can ever, I don't know, they may be able to, but I don't think they can ever do that. So yeah.
Okay, one more question.
In talking about quality, how are we measuring quality? How are we measuring quality of work?
I guess quality, as a broad definition, is patients are happy with it. That's probably your first broadest definition of quality. But in order for clinicians, I think, to feel that they're doing quality work, it's about having those clinical discussions and reviewing what they're doing through things like audits or having peer review, peer support, clinicians talking to each other about clinical things to try and ensure that things are done consistently and to a certain standard. And for me, quality in the end is patients being happy and dentists and dental practitioners or clinicians being satisfied.
Could I just add to that too, that actually quality would be around meeting the needs of the patient. Now, it doesn't necessarily mean that they're happy with a filling or a root canal treatment or whatever, but it's around, is that filling and that root canal treatment appropriate treatment for that case? So it's not just about the quality of a filling or the quality of a procedure or an implant. Is the first question, should the patient have had this treatment? Do they need it? Does it add to their health or not? So it's a really broad question to ask, what is quality? You can do it at different levels. You can do it at the tooth level, at the individual level, at the organization level. So it's broad.
We tie duty of care in there as well. If we see by stopping someone with a high risk going through the restorative cycle as our duty of care. And some people might say that's poor quality or whatever. But if you if you determine what the duty of care is, then you say, well, our duty of care is to make you have a long-term health outcome, and doing fillings isn't going to do that. So, just my comment. Yeah.
And that also might involve changing the way patients view what is expected. Often you'll have patients that expect a filling, or patients that go to a doctor and expect a prescription, but that might not be what the best thing is. So it's also about having that discussion and getting them thinking about oral health, and oral health provision has changed a lot from the way it was 30, 40 years ago, and I think there's a level of education that we need to provide to the public so that they understand that the world's changed a little bit and we provide services a little bit differently too.
Great. Please join me in thanking the team.